Hello, everyone. My name is Jamal Habballah. I am the past president of the Pan Arab Vascular Surgical Society, PAVSS. And on behalf of PAVSS, I would like to welcome you all to our monthly educational activity. As you know, we alternate 1 month journal club and 1 month webinar. And this month, it's the webinar session. And we are really delighted to have been able to assemble a very solid group of experts to talk about a very challenging topic, type B aortic dissection. This is a topic, as you know, the has underwent a lot of advances over the past decade, and although the medical therapy continues to be a great part of the treatment, the advances in endovascular therapy and the better understanding of the remodeling of the aortic pathology have led to a lot of questions. And for that, we have assembled a number of panelists to help us in the discussion, starting with Dr. Rana Afifi, who is a very experienced vascular surgeon who focuses on complex aortic surgery at McGovern University, at McGovern Medical School at UT Health. We are also delighted to have with us Dr. Hazem Beiruti, who is now a head of the aortic program and director of the vascular program at the Hamad Medical Corporation in Doha. And we're delighted to have with us Dr. Luay Qabbani, who is the vice chair of research at Henry Ford, the board certified vascular surgeon and cardiothoracic surgeon with a strong interest in aortic pathology. Now, the presenter is Dr. Firas Musa, who most of you know him or have heard of him. He's born and raised in Baghdad. He started his career at the American University of Beirut and then migrated to the US in the 90s and trained at Hopkins and Baylor. His first job was at NYU, where he built a reputation for aortic dissection. He is currently the national PI on the Improve AD trial and professor of surgery at UT Houston. And he will be talking to us today about the updates in the complex management of type B aortic dissection. Dr. Firas, the floor is yours.
You can hear me. Okay. Thank you, Dr. Habballah. And it's a great honor to be with you today, everyone. PAVSS, PAVSS, and an outstanding group of panelists, and I'm looking forward to the discussion. So to get to it, I'm going to try to talk to you about where we are today and how we got here, where we are doing, and what comes next. So these are my disclosures. So aortic section, and not that I don't remember it to be that common in the Arab world, but I'm pretty sure it does exist because the same pathology exists, probably less illicit drug use, but still hypertension is ubiquitous in the MENA. So 3 to 4 cases per 100,000. Mean age is young people, 63, mostly men, at least of what we know, mostly related to uncontrolled hypertension. It's really, before anything else, it's a disease of uncontrolled hypertension, regardless of how you treat it. It is still, and that's what Dr. Habballah said, the medical treatment has also gone major transformation and still ongoing transformation as we go on. Connective tissue disorder is a real thing. And definitely, and illicit drug use definitely rampant in the United States and everywhere in the world. So that plays a big role in spiking the blood pressure. So that's really what happens in the true and false lumen, if you will. It's like a piece of chips, if you will. This is from the recent New England Journal paper. And I just want to draw to your attention. Actually, this is not a pet peeve of mine, but that's actually a very important distinction between what is type A and what is type B. I think if you're going to use Stanford classification or DeBakey, let's stick to Stanford classification for 1 second. So type A for Stanford classification, a tear that is anywhere proximal to kind of the middle of the innominate artery. So that's at least by And I credit Craig Miller for telling me this. This was the intention of Pat Daly and Dr. Shumway when they came up with the Stanford classification. Be it as it may, take it. I don't know how much banking how much take it to the bank, but that's type A. Anything in the middle of the innominate or proximal to that, anything beyond that is a type B. So if you have an arch or in the middle of the arch between the innominate and the left carotid, technically it's a Stanford B dissection. Now, I think this is all becomes semantics and not irrelevant, but I think this is better classification, the SVS STS. Actually, I think if anything came out of that reporting standard is this classification is very useful. You can relate that to zone 0. You could see the area, and you can just have it on your phone, and you could say, I have somebody who is a zone 1 to 9, or 2 to 5, and that's really very much more more descriptive and accurate, as a matter of fact, to describe what's going on. So, as you know, A and B, complicated, uncomplicated. Still the academic definition of complicated is rupture, and which is rupture, shock, and malperfusion anywhere of the end organs. Now, this is to move ahead. So I'm going to share quickly. This is mostly going to be around uncomplicated dissection, because complicated dissection is like acute appendicitis. It's got to come out. You got to treat it. It's not no delays and so on. It's an acute emergency no matter what, and this is what happens. So, for instance, for malperfusion, again, this is from the same paper. It could be a static malperfusion, which is the true lumen is obliterated and a thrombus in and out the false lumen. That is static. You got to go in and fix it. The dynamic, as we all know, is a flap going in and out, and that dynamic obstruction could many times, not always, get fixed when you actually, and you could see here, it's get fixed with a blood pressure control. So you bring the blood pressure down. This also, I'll touch on it in a minute, has its own kind of art and science. But definitely, we've all seen these patients where there is definitely compression of the true lumen going into the celiac or the SMA, and patient has actual clinical and laboratory signs beside the imaging of malperfusion. So that's the other thing. You've got to have the 3 component in order to define somebody who's having complicated versus uncomplicated: lab, clinical, and imaging. So this is a case that presented. Actually, I can't remember. Freno was no, she wasn't on call on that one. So I was on call for the vascular, and the cardiac surgeon also was on call. Here's a patient comes in, 68-year-old with. I'm going to walk you through this is just, you could see the tear starts in the descending aorta and goes on. And I got too excited because I thought this would be a nice trial case to present. And here you could see a little bit the dissections start distal to the left subclavian, and most of the true lumen is actually false lumen is thrombosed. So admit the guy to the ICU, and CT scans zone 2 to 9 without any signs of malperfusion. He has, if I play you this one more time, he does have, however, if you look a little bit more, is a mediastinal hematoma that you could see right in that area. There's a thick rind around the heart and behind the sternum that you could see. It's a mediastinal hematoma. So that's what was unusual for a type B aortic section to have a mediastinal hematoma. The guy gets an echo, and sure enough, he has a pericardial effusion. It's not really acting like a tamponade patient. So take the patient to the operating room with the cardiac surgeon for a TBE and a pericardial window, and 300 cc of blood gets out. We stent the patient, nothing, everybody's high five, doing well. That's a completion cone beam CT, and goes back to the ICU. And then a day later, actually, post-op day 3, excuse me, patient developed rising lactic acidosis. Repeat CT shows, here's a repeat CT. And it tells, so I stopped at just covering the entry care, and here you go. That is your cine right there. So the patient in the ICU developed distended belly with signs of mesenteric ischemia, as you can see the gut here. So clearly, you take the patient back to the operating room and you extend the TVAR, put in a petticoat. If I have my views on it, but in any case, this patient needed it. You get into the selective branches of the SMA, the celiac. You stent each one of them separately in cone beam CT. Everything looks nice and open. Celiac, everything is distended and so on. So that's really a little bit of an extreme. We wrote this up. Greg Estrella, Tony Estrella's son, wrote this up as a case report, and this is the completion CT scans, and you can see the patient. And so, moral of the story: complicated aortic section. It's a fire drill. It's an important take the patient to the operating room, have the skills to recognize in the ICU. That's where a multidisciplinary team ICU care is critical, in addition to your skill as a cardiac and vascular group, and be able to recognize a problem, work together with the other team members and fix it. So it's really, that's the easy part. Now, the hard part is when you have uncomplicated aortic section, and I'm here to talk to you about it. And I'm happy to share thoughts and ideas about this patient and so on. But that's really treating malperfusion and rupture is kind of a where it all started. And now we're talking about uncomplicated with no rupture, no malperfusion. So this is a case, 68-year-old woman, actual patient of mine that I still follow, comes in. Let's see how many people will treat this with. Here's a subclavian. Here is her tear, right, and then or a little bit down right here. And then you could see this section. Unfortunately, I saw her before the trial started because she's a nurse also, and and she's very motivated to be part of the trial. But she's now an advocate to that. Sorry. So I'm trying. This is stuck. So 68-year-old woman, type B aortic section, goes from zone 2 to zone 9. So again, let's just play it one last time. Type B aortic section goes down from 2 to 9, probably, or even, again, let's see, celiac comes in, SMA has a dissection and stop in zone 6. So hypertension, ascending is dilated to the proximal aorta is 4.2. So this patient, as I just presented to you, anywhere with you, any facility now, anybody who's listening to this would admit this patient to the operating room. You have goal management of blood pressure 120 minus blood pressure of diastolic of heart rate less than 80. First line, I changed this to not me changing it to labetalol, but there is data. But most sites will start as malol. However, there is data out there on being other new drugs to use. Second line is cardine and nitroglycerin and nipride. And you concentrate medication, you watch the urine output. I mean, this has been going on forever. You take them out of the ICU in a few days. So the newer, I guess this is University of Wisconsin, and I think we wrote about it in the seminar issue. The first line therapy, you start oral medication the day they present, and that was usually amlodipine, 5 milligram. You increase that to 10 if required. The second line, you add an ACE inhibitor or ARB, and third line, you get cardiology consult. And this multidisciplinary is going to come up again and again. It is not really only vascular surgery or cardiac surgery or whoever, or just cardiology. It's a teamwork to treat even the simplest, I guess, quotation, because there's no such thing, of type B aortic dissection. The general measures, you repeat the CT scan, and you gotta have to set a rule for 24 to 48 hours, even for uncomplicated, to you watch for size to changes, especially if there's new signs. So this is an important consideration. Recurrent pain, just for those who take that as an indication, recurrent or persistent pain. Recurrent pain is when the pain patient presents in the emergency department has a pain in the back or the chest and so on, and the pain abates or goes away. Recurrent pain is a different kind of pain. I mean, you can have, if you had back pain and now you have chest pain, that is a different kind of pain. That is definitely an indication for re-imaging. Um, Unrelenting pain is different. It's the same pain continues despite you're going up on the narcotics and the blood pressure is well controlled. That is persistent pain. Recurrent pain goes away and comes back in a different area. Probably that is more worrisome than the same pain coming back again. So yeah, there's a lot of things to play. That's why I say always that it's not really for a small hospital to treat even uncomplicated type B dissection, because you need a really cardiac rehab. Patients need psychological support, need counseling, need adjustment for blood pressure measurements for a long period of time, and outpatient referral and so on. And overall, so that brings me to why I'm not going to dwell on why we need a trial, but I'm going to present to you. And by the way, this is what we're trying to do. So gives me always a pleasure to present, because it goes through Houston for the most part. Still, Houston plays a big role. So King Charles, as we all know, died from type A aortic dissection in 1760. Okay. And you can argue from 1760 to 2026, not much has changed, even though we did say that TVAR and medical therapy changed, but which did. But more or less, we still need data. DeBakey 54, the Stanford classification. These are the milestones that change the face of how we do these things. And then it's a trivia here for many who do not know how medical therapy started. So in 1963, a cardiac surgeon, and a pharmacist described this. So Bill Wheat is a cardiac surgeon, was at the University of Florida, and the pharmacist, I don't know how it happened that they noticed that the turkeys are dying right around Thanksgiving, and because of blood pressure, because of the grain changed, and their feeding is changed, so their blood pressure was shooting up to 250, and the turkeys were dying. So then they started giving them reserpine to lower their blood pressure, and the turkey survived, only to be killed for Thanksgiving dinner. However, that led to the idea that you actually need, close alliance at the time with the veterinary medicine, which now translates into cardiology, is necessary to do this. So that's really what led to medical therapy. And believe it or not, this is really the basis of how we got to medical therapy. Okay, to lower the blood pressure so people do not die. And because if you sustain blood pressure at 250, it's clearly that's not going to work. So we're grateful. I'm always grateful to Mike Dake till today, and IRAD same way. Chris Nienaber in 2013 published the INSTA trial. These are the milestones that happened throughout. So why do we need a trial? We do need that TVAR. It has been proposed that upfront TVAR will allow remodeling, as mentioned earlier, lead to reduced rate long-term dilation, probably, unless aortic-related death. So it must be done within a time period. So it could lead to relamination of that aorta as opposed to being a thick septum. So it does make sense to do a TVAR for patients with uncomplicated type B dissection. There is the data to I'm not going to bore you with that, but I just want to tell you that medical therapy versus TVAR in the long term, short term, in terms of mortality and aortic related events, the data is all over. You can have a mortality anywhere from 16 to 40%, which is a huge range. TVAR also from 11 to 40%, and 5-year event is really up to 2/3 of patients on medical therapy have an event. But what is the event? God knows what it is. And TVAR, same thing, 30%. What is an event? If an event is just to come in to get an angio and confirm everything is fine, it's different than having a rupture. So really, the data is not clear about what is the role of each, but we do know that TVAR is good, medical therapy is good, but not great. TVAR has its own risk, and so on. Mortality and event rate, both are all over the map. So the best data that we have is still from 2013. That did not really show mortality difference for stenting did improve remodeling. And a system, and then you have adsorb, which is kind of a series. It's a series, however, it's a prospectively collected 30 patients in each arm, shows that better remodeling. It was not really enough, and a meta-analysis slightly in favor of EVAR over. So equipoise exists. That's why we need a trial. Both have harm and good. So that's where we are today. So I'm not going to bore you with the guidelines. I'm just going to say the guidelines are pretty weak in there. So level of evidence is C, which means expert opinion. It's like all of us here sit down and say, well, Hazem, I think you should do this. No, Firas, you should do this. Renaud says, no, this is my opinion. And that we reach a consensus at the end of the day. And that's really not really a good way of conducting science. But that's rampant, not only in aortic dissection. Most of the things that we do in surgery, cardiologists do much better job. I mean, on surgery, I think vascular surgeons credited for the best CLI now. They're not credited. CREST is partly credited to us, but it's really led by neurology, to be honest, to get it done. It's in the SVS top number one priority is the question of the trial, and remains to be the top question for the SVS. So this is the trial. Hypothesis is simple: upfront TVAR versus standard of care, which is TVAR when you need it. And inclusion is very open. Zone 1 TVAR is allowed anywhere from 2 weeks or within 6 weeks of the index admission. And exclusion, really very liberal. We just don't take patients who had a prior like DeBakey 1 classification. But if you had a prior aortic repair in the ascending, it's okay if they come back with. This is the design of the trial. So it's 1,100 patients randomly assigned to each arm. Primary endpoint for all-cause mortality. So these are the questions that any of you will say, well, what about this or that or this or that or this? I mean, a million other questions you could sit and say, I think I know the answer. I know the answer for sure. I mean, just pick a simple TBE, thoracic branch device versus simple TVAR. Does that make a difference? When do you intervene? How long do you put a stent graft for? Is it really cost effective versus one? Do you improve the quality of life of the patient? How about if the patient has a genetic disorder of unknown significance? These are a lot of those. So, well, about what happens in the aorta if you leave it alone in terms of longitudinal imaging? We don't have any of this data. If anybody has 100 patients that they followed for 5 years or full of set of data, then I'll quit the trial and I'll tell you this would be an amazing thing. Same thing. We don't really know which is beta blocker, calcium channel blocker, and so on. And fulsome. And definitely high risk features are important, but have never been validated prospectively, and we definitely should look into that in more detail. Though many of those questions got answered, I'm grateful to 3 PAVSS members, Shireen, Inas, and Lei, for contrast, this is instead nowadays improved AD special edition addressing many of the questions that I just raised. Anything so far before I dive into the future of what's going to happen, and at least in my view? I don't know if about type A, about complicated versus uncomplicated. Or shall I just carry on and wait
Let's
till the
carry
end?
on, and then we leave it
Okay.
for the questions at the end.
Okay. All right. I always like this quote from JFK. In this time, the world do not stand still. Change is a law of life. And we all are experts in change. I mean, we came from long and different parts of the world, and continue to and our part of the world is always changing. And those who look only to the past and the present are certain to miss the future. So here's what I think is the future for what we're doing and what we're talking about. So I think imaging is going to transform what we do. And CT scan is not going anywhere, but I do definitely think that 4D flow MR is probably right around the corner to be cheap and available in every center. So here you could see, this is just a dynamic MR, but I mean, the 4D floor MR will definitely transform the way the pressure mediated false lumen growth. Many of the things that we take for just size, for instance, diameter, will become not obsolete, but they will become not just the only factor to factor in, so to speak. Complex variable flow pattern, and many of you come across CFD, the computational fluid dynamics, high volume turbulent flow, but definitely this is going to be mainstream. That's going to change the way we actually treat, because you could treat even like if you collect 100 patients in the trial and you run 4D MR on 100 of them in a separate study, not within the trial itself, that is by itself is a very valuable tool for us to know. And then, and I'll talk about AI in 1 second, but this is actually even I think is more exciting. So is aortic dynamics in shape and size and derivative space. So this is the work of one of Luka Pasivavchek, who's is a vascular surgeon at University of Chicago. The other one was by Nick Burris, who's at University of Wisconsin now in Madison. So this is the study from TVAR patients who were in the Gore and the Medtronic pivotal trial for TVAR, and it goes into difference in shape versus and diameter, different shape and diameter, and some of them get stent graft and they do not change in shape. Some of them with medications they change in shape and they shrink. They don't change in shape and shrink. So the question is, what happens to the shape of the aorta and what happens to the diameter of the aorta? These two are not always in the same line, and those who change in shape and diameter do better than those who only change in diameter or only change in shape. And this is not a guaranteed what we do in our treatment. And that is really fascinating, because then some of them who you think they shrink over time, but they don't change in shape, they go on and rupture. So that's real. And same thing is in AAA. The AAA, you could see that it has an endoleak, for instance, but the diameter is shrinking, or no endoleak and the diameter is smaller, and then somehow doesn't happen in that much, but sac shrinkage or sac remaining stable in an EVAR. Let's say you're 5.3 for 2 years, and all of a sudden an EVAR ruptures or the aneurysm ruptures. And that's where shape versus biology versus, all these we think play a role in AAA. Same thing in TVAR and dissection. What happens in the flow dynamics? So despite the diameter staying the same, these are all good factors to consider. And we're only starting to scratch the surface, but that's really what people, keep people up at night to try to solve these questions in the world of physics and imaging and so on. So So again, if I have a crystal ball, that's borrowed from Gustavo, his artificial intelligence, we all agree centralization of care, which is far in this country than anywhere else, because you have a C arm and you have you have a wire, then you get a T bar for sure. Then that's and that may be good, work out in 7 out of 10 times, but guess what? 3 out of 10 you may cause harm. And even if you don't cause harm, this may do inflate cost of healthcare, and does inflate healthcare costs. Non-radiation is, I did not talk about it, but LumiGuide and other things are real and cutting on our radiation exposure, which is great. But I do think that imaging is the key thing. I'm going to touch on one last thing this before I close. This is a digital mammography and digital breast study. Okay, simulated breast images for virtual patients. You had patients, you created their double twin or digital twin. Okay, in breast cancer patients. Okay, results of an in silico trial run parallel. So you have 2,900 patients that you double that. Okay, and those clinical trials were both imaging method used in 400 women, and you could see the images are pretty pretty similar. You compare one next to the other. This is the real, this is the simulated, and you reduce the sample size from 3,000 almost to 300 patients. Okay, this is a virtual trial based on the actual trial by creating a digital twin for the actual trial. It does deliver less patients, definitely less money. Less patient means less money, faster. I mean, you could do this in a week as opposed to 10 years. Okay, with definitely almost identical results. So it's a fascinating field. It's been done in pharma. I mean, Merck use it. Many other pharma companies are investing hundreds of millions to create a digital twin for their cohort of patients to test a drug. Same thing in space. What happens when you send somebody to space on their, cardiovascular system? So shorter, cheaper, smaller sample size, test potential for contentious monitoring adaptive trial design obviously has its own limitation, validating accuracy and patient data privacy. But there is a big push from the federal government here in the US to adapt this into devices. So FDA now has a whole section on digital twin trials to test, heart rhythm problems. And any stent that you want to do is probably going to be subject, not right now, but it's healthcare is slow to adapt to the technologies that are used in space or other, but it will be within the next, I'm not going to say 10, it's going to be next 3 to 5 years. So here's the Improve AD trial model. So you have collect these patients, you create the digital model, okay? Then you create the digital twin, you subject them to the 2 different treatment modalities, the medical therapy and the TVAR, and you predict the outcome. This is actually the next grant that's going in September. Okay, combining these things, in Houston we have an outstanding school of bioinformatics that actually have a long-standing credibility on creating the model here, and collaborating with the guy in Chicago that I shared with you is imaging thing. You can actually propose each one of them is a separate grant. I mean, you can creating this as a grant, the digital twin, collecting the images and in a morphological way is a grant, and then running the in silico trial is a grant. Combine them all 3 in one, I think, is the future of what we're going to do and how we're going to study this in the future. So I hope I gave you an idea of where we are how we got here, where we are, and what is in store for. I think it all boils down to imaging and development in imaging and AI, and how does that translate into what we do? Because definitely, it's not going to be the same um, on a global level, but definitely it's gonna, and we as a society, PAVSS gotta have to lead in that. And I think we do have the leaders in the field here, actually, between Rena and here in the U.S., Luay and Shireen and Inas and Carlos and so on and so forth. All these folks, and we draw our strength obviously from the bigger society that is in attendance today. So we stand on the giant's shoulders of Jamaat Hezbollah. I personally do. So I'm going to finish with this question for you all, and you don't have to answer. Rena has heard it before. Is there ever a reason to treat any patient with uncomplicated type B dissection outside a randomized trial? You can reach me on my cell phone or this is my contact info, and or text me, WhatsApp me, or the group, and I look forward to hearing from you all. I'm going to close here and look forward to the discussion. Thank you.
Well, thank you very much, Firas, for a very informative presentation. And as you mentioned, we have a lot of unresolved questions and unresolved situations that we still don't know what's the ideal and what's the correct thing to do 100%. And you mentioned imaging, imaging, imaging. And here in our part of the world, and many of our audience and the ones of PAVSS are in this part of the world, we don't have always all the sophisticated imaging that you are talking about yet. So we need some kind of some help in trying to identify, do some risk stratification, and identify who are the ones that really we should be a little bit more aggressive or more attempting TVAR instead of medical therapy. You mentioned the persistent and recurrent pain, or at a different location, or the resistant hypertension. But how about the other factors like the initial aortic diameter, the size of the false lumen, the thrombosis of the false lumen? So give us some, and I would like to ask you that question. I'd like to ask the panel to share with us their thoughts on these things.
Yeah, no, thanks, Jamal. I personally, I agree that these are important factors for the bedside decision-making process. For you treating a patient tonight, and you want to know if this patient is going to need a stent graft or not. So, beside, you're going to admit them to the ICU. You're going to treat their blood pressure and their heart rate and pay attention to every little detail and so on, as we discussed. The imaging criteria to use, to guide you. I mean, I think initial aortic diameter aside, which I think is an important consideration. Initial aortic diameter of 40, for instance, is an important consideration. The remaining are not trigger for TVAR, not a trigger for TVAR. They are a trigger for close observation. Okay, and they may pan out to be just as, and you could say that's the same thing about every TBAD. But these are like the initial, I happen to think that the initial tear size that is close to the left subclavian is an important consideration. But that's not a trigger for me for a TVAR that night. Same thing, readmission for pain is different than readmission because they ran out of medications. So there is I guess what I'm trying to say is individualized therapy is good. Close follow-up is the best. Size of 40 millimeter, or actually, there is data that shows if it's not this initial aortic diameter that is the key, it is the repeat CT scan is a month later. And if you show that this grew by 2 millimeters from the initial scan, then that may lead to future aortic event. Okay. This is a discussion that you will have with the patient. I'm confusing you, I know. So I'm just saying that you would like to have a close follow-up on these patients that you think are high risk, because remember, these high risk used to be high risk for a big open thoracoabdominal aneurysm. That does not exist anymore in the US as frequent as it used to be back in the day. Now BVAR and even actually in the MENA, you have all the access to the same devices. So so the fear of a thoracoabdominal, it's only Caselli and Safi could do. It's not the same as it used to be 10, 15 years ago. But I'd be very interested to what the panelists would say, and Rana and Loe and everybody.
Afif, Rana, please go ahead.
I'll shed some. So first of all, there are things that I do agree with what Fras saying. Part of it is that even during the writing process of the guidelines that hopefully will come out soon, the data that we were able to kind of reproduce as far as high risk features was only size. Everything else was non-reproducible, meaning that there are trials that have shown one time that recurrent pain or false lumen thrombus, all of those things can be a high risk. But having said that, there was no ability. The studies that tried to reproduce us failed in it. So the only actually high risk feature that was reproducible was the size. And I do agree with Firas that for me, it's more the change in size than anything. Having said that, you can't take the experience out of it, which is why I do still think there is an importance to the expert opinion in it. Having said that, that doesn't mean this is against enrolling in the trial. This is important to enroll in the trial to try to prove that instincts that we all are having, or we've seen it in so many patients. So in Houston, historically, our data that we've published about aortic dissection, sometimes it took 11 days for the pain to kind of resolve in some patients. So having pain the first 24 hours, 48 hours is not necessarily always a sign. Having said that, someone who you controlled the blood pressure completely, they have had a couple of days that we were without pain and then having again another episode of pain. Those are usually things that, for me, raise the question. I've had a few patients where suddenly they developed a retrograde type A, right? And that was their new pain, or they've had a new dissection or expanded. So I would still take these things under consideration based on individualizing the patient. It's very difficult sometimes to kind of go and say there is pain and there is pain. Patient who can't find a place to stay still in bed and they're just, they can't live despite everything that you're giving them. As much as we say there isn't enough data, I think most of us here feel very uncomfortable not treating them. And I think that's part of what pushes us to do some of the things that we do nowadays. But I do think that the importance of the trial is to try to prove some of those things that we're doing based on experience, instinct, or what we're looking at. It's just important for people to know that there isn't real evidence that supports the high-risk features yet. And that is unfortunate. I wish I would say that there is, but there isn't. And that's for even when you look into it to writing the guidelines. So the data there is not sufficient. As far as timing, there were some questions that I saw. As far as timing for when do you do CT scan, I personally don't do it within 24 hours to 48 hours if the patient is clinically okay. But I try to do what I call graduation, meaning before they leave the hospital, just to make sure that we're not missing a rapid expansion within that first week. And if nothing happened in that first week, then I follow up in clinic and I repeat the imaging within a month or two. The largest amount at least from our experience and in our own data, and when we have almost 1,000 patients with type A and type B that we follow and see, over 1,000, that basically the first 6 months is when we've seen the largest amount of growth. If they did not grow within the first 6 months, there's a good chance they'll stay more stable, and that's based on just our experience from our own data. So the first few months of follow-up for me are very important. So I think that there is no question about what you do when you have the complicated type B. I think with the uncomplicated, you need to consider the patient and their ability to be there to follow up. Not that putting a TFR in makes it any better, because you still need to follow up with those patients, but you need to understand what your environment is. Do you have the capabilities of doing these procedures later? One of the things that I've struggled with, and I would love to hear what you guys have think. I've had in the past, people have called me from areas in the Middle East and said, "Hey, should we do a TVAR, because if this patient degenerates and it's now open and they're young, that was someone who's in their 30s, and now they have a thoraco and they require open and not necessarily endo, do we have the capabilities of doing it? Are there enough people to do it? Should that be a consideration or not?" And I still think that we don't have enough data to say one way or another. So I think that's the biggest challenge, in my opinion.
Right. Well, thank you for mentioning the issue of age, because young patients are always a concern, and how long are they going to be before this gradually gets larger, and etc. So let me
And
ask.
a higher risk for genetic. I would.
Genetic testing with connective tissue
So
disorder. Some of them
I would.
bring up.
First of all, just the first thing, if Shireen was here, she would say, "Don't use connective tissue disorder." So I am a good student. I repeat what she says. Dr. Shalhoub, that's her expertise. But the reason is that it's not just connective tissue; there are also muscular, and so it's the genetically triggered or hereditary disease. The younger they are, I test all of them, and I suspect that. And I think in the chat or the question, there was a question about whether you do TVAR those in the uncomplicated. I don't. That's not indication. If they're uncomplicated, I still treat them medically, follow closely. They might require open repair sooner. The reason is they do have a higher risk for new entry tears, distally, and retrograde type A. They have it. Dr. Shalhoub's paper had demonstrated almost 30% retrograde type A in those patients. And so uncomplicated type B in patients with genetic, or that I suspect that they have a genetically triggered disease, I don't do a TVAR unless it's complicated, and I'm right now doing it as a bridge to save their life.
Okay. So as far as anatomy, on the initial CT scan, we have concluded that it's only the size that's the biggest predictor. The size of the false lumen, or whether it's thrombose or the entry or no entry, these are currently not, we don't have yet evidence, and we're waiting for the trial. So let's talk about other things. You talked about the timing, and we know they have the hyperacute, acute, and subacute, etc. So as far if we have to intervene, we'd always and uncomplicated. The subacute is what you would go for, Dr. Qabbani. Would you want to share some thoughts on that? How?
Yeah. So you really don't want to do the acute phase unless you have a complication. I think the intima is still very friable. I think there's a higher risk of retrograde dissections, and you really want to wait a few weeks until the septum and then until this tear heals. So unless you have acute complication, you want to wait at least 2 weeks. I think that's the consensus. It makes sense. The thing I would advocate, and we talked a little bit about this, is blood pressure control. Firas mentioned this. You don't want the blood pressure to go down really fast in these patients. And the problem is these patients live at a higher blood pressure to about 150s, 160s, and you put them down pretty fast to 120s. There's a higher chance of stroke. So you want to get them down, and what we've done at Ford is we get them down until the pain goes away, and we treat them like malignant hypertension. So I would definitely advocate for that. And then we wait, and if they don't have any malperfusions or they don't have any signs of rupture, we wait as long as we need to. And the thing that I wait for is increase in size, and I think Rana and Firas alluded to this. I think the change in size, especially in the first few months after a dissection, is important for me. If I see a change in size, 5 millimeters in 6 months, I'm more inclined to treat these.
Okay, very good. Dr. Beirut,
You know,
any
just to tell you about the timing, just to tell you about how crazy is timing, I agree with everything Lay said, as always. And I do agree 2 weeks. But it's adsorb, you know, the average day, it's an uncomplicated trial. Average timing was 2.5 days for TVAR in an acute setting. It's so again, I agree, but instead, when they stented too early, they ended up with a lot of complication in the TVAR arm. So we migrated naturally and rightfully so to the 2 week time period. But remember, adsorb was that anyway, and we do that for a complicated dissection. The patient less, I mean, they are at a high chance of retrograde dissection for a variety of reasons, but they tend to be okay. But yeah, Hazem, I'm sorry.
Hazem, you are muted. Could you unmute yourself and then give
Yes.
us some
Do you
tips?
hear me? Yes.
Yes,
Thank
yes,
you.
yeah.
Thank you. I completely agree that at present the evidence supporting most proposed high risk future is still limited, and that aortic size, or perhaps even more importantly, interval growth, remains the most reproducible predictor. But from other side, at the same time, I think aortic remodeling may deserve a clearer place in our future guidelines, not necessarily as an acute indication for intervention, but as an important treatment goal and follow-up endpoint after TVAR. I think looking ahead, perhaps AI could help bridge the evidence gap by analyzing thousands of serial CTs scans, as you said also, Firas, from patients with type B aortic dissection and correlating imaging findings with long-term outcomes. So it could be that AI may eventually help predict which patients are likely to achieve favorable remodeling and which patients are at risk of adverse remodeling or late aneurysmal degeneration, which is very important point, I think. And so perhaps future guidelines will not only define when we should intervene, but also how we measure success, failure, and individualized treatment, surveillance after treatment. I would be very interesting to hear your thought on that.
Well, I'll start briefly. Thanks, Hazem. I mean, so aortic remodeling is important, but as an endpoint, it's called a surrogate endpoint, meaning it's an endpoint to show us that the aorta is healing or healed. That's remodeling. It's different than false lumen thrombosis. It's an important consideration, but it's never linked, crazy enough, at least not to my knowledge, remodeling and mortality. At the end of the day, you want to see that the patient survived, did not die from rupture, did not. It makes sense, but never linked. So we are not doing well in even this linking that to mortality or quality of life. It's something that matters to the patient, because if you tell the patient you have an aortic remodeling, the patient is not going to necessarily appreciate that. You got to tell them the aorta looks great and healed and all that, but internally within yourself, you cannot say you mitigated the chance that this person will die. And that's really what you're trying to prevent in anything that is like you treat, you change the plaque in the carotid, how it looks with statin, but if the patient goes on and develop a stroke or die from a stroke, then statin didn't do much for you. So this is a similar idea that I share with you. Remodeling is important, but using a surrogate endpoint throughout history in medicine. Some surrogates are better than the others, but in our society in vascular surgery, we use this quite often. And that makes me think: how did we translate that to something matters to the patient? But I'm interested. That's me being the purist trialist side of me, but I see the practical side of me is important. But I'm interested in the others as well and their input. Obviously, I'm here to learn.
Let me move the discussion into something additional about the technical aspects. I mean, do we have any special tips that you'd like to share about TVAR during acute type B dissection? You mentioned you have some reservation about the petite or the dissection stent, the petite coat, or any of the others. Can you know the
Right.
sizing? How do you decide what size
Right.
do you use? Give us some technical tips.
Yeah.
And I need
Yeah,
that
yeah.
from you and all the panelists, because us who don't see a lot of them, although we're seeing, to be honest with you, we're seeing more and more frequently aortic dissection, at least at the American University of Beirut. And Dr. Haddad is among the audience, and we have our own multidisciplinary kind of approach to them. But I think we're seeing more of them, and we need to we can appreciate any tips that you give us on that.
Okay. So I think having an OR that is well stocked, and I imagine ABs is similar to here in Houston and many places. The case is done. I think IVUS is indispensable. From the access site on, you got to confirm that your wire is in the true lumen. You measurement, I think, from the CT is inner to inner wall with the classic 10% 10% oversizing, maybe, or you can have it even 1-to-1, meaning if the true and false lumen diameter are altogether is a 32, you probably, your next device will be at 36, or you don't want to go crazy and make it at 40, even though, or some people measure the concavity or the full true lumen, the true lumen up and down, and that gives you an estimate, or you combine the two. So measurement, IVUS, TEE plus minus for complicated cases. I think TEE is critical. Then we're not talking about connective tissue disorder. That's a different. Open exposure probably is a better deal. Then I tend to cover probably just the proximal tear and do not go down to the celiac routinely. Petticoat, I think, is the problem I have with it is I do not have a use for it. Even in malperfusion, I tend to go into the selective branches, but that I think stabilize is probably the better use for that bare stent than just laying down in complicated cases, laying down the bare stents. These are the tips of my head, but yeah, I mean the rest of the panelists probably could add more.
I have things that that I have maybe a different opinion about. So the first thing I think that I would say, if you have the access to intravascular ultrasound, it's crucial. And for me, the importance of it is if you're in a place where you want to invest in one thing and you can try to do that, and taking into consideration that not everything is available, I think getting an intravascular ultrasound capability is important, just because maintaining true lumen access is crucial when you're trying to treat these patients. And so I do think if you're looking into investing into something so that you can improve your ability to service these patients, I think intravascular ultrasound is a crucial one. Having said that, there are sometimes tools like TEE that if you have a good person who can look at the descending and let you know if it's in the true or false lumen, the wire, that can bypass it. But I actually think the IVUS has a huge role. As far as stent sizing, I usually try to 1-to-1, maybe go with the 10%, only because, again, remember, it depends on the patient. CT is dynamic, and CT is static, but it's a static picture of a dynamic process. So if you had captured it in the time that it was actually smaller diameter, then you might be undersizing. So not more, though, than 10%, not in the acute phase. I don't go more than that. I avoid ballooning, so I actually disagree with the stabilize for the acute dissection. If anything, petticoat is for me to go to if there is malperfusion. And with petticoat, I've avoided stenting of specific vessels by doing the petticoat in certain cases. So my go-to, I used to only do the entry tear, but with the recent, more especially if you need to extend and then you have to come back. So now my approach is usually to try to cover to the celiac, especially if I do have a lumbar drain or the ability to do lumbar drain, because the biggest thing that you would hesitate about coverage all the way to the celiac is that you want to make sure you don't increase the risk of paralysis, right? And so if you don't have the capabilities of putting a lumbar drain preventively or emergently, then I would be cautious, and covering the entry tear alone should be sufficient, hopefully. But if you do have those capabilities and you're able to do that, then being more aggressive to the celiac is something that I would consider. If that,
You mean cover all the way to the celiac with a covered graft, not with the petit, with the
especially, you need to think that it's one of the complications of acute type B can be a rupture. And sometimes you don't know where the rupture is. And if you don't cover the entire level to the celiac, you might not seal your area of rupture. And so again, if I do that, if I have the ability to monitor, if I'm not too concerned about paralysis, then I would do the covered just a little bit above the celiac. And then if that does not resolve a malperfusion, then a petticoat would come next for me, making sure the technical aspect of the petticoat is that you need to make sure how you're measuring your length, so that if you do need to do an overlap between two stents that are bare metal, you need to make sure that you're not doing the overlap in front of the visceral vessels, just because then you're going to make your life more complicated and miserable if you do need to access the vessels themselves. So those are technical things so if you're planning that, and if you have a case like that, you want to talk, I'm pretty sure any of us here would be happy to have our contact, ask people for those tips and tricks. So those are things that are tricky to learn at the beginning. And I do that, and the petticoat in many cases would resolve the perfusion, the malperfusion. But if you do need to then to go to the specific vessels, you still have the ability to do that through the uncovered. Stabilize, I think it's a good approach for the chronic. As I said, I avoid ballooning in acute phase. That's a risk for rupture. That's a risk for retrograde. That's a risk for new. So for me, ballooning I avoid it at any cost if possible in the acute phase. Even in patients with known hereditary thoracic aortic disease or genetics, in the acute phase, I still would go first with TVAR. I mean, our data, there was a question in the chat about what's the role of open. The role of open in the acute has decreased, even in our institution where we have the experts for the open, right? We don't do that anymore for acute phase unless it's rupture and anatomically unsuitable for us to do endo. But endo would still be the bridge in these patients to get them through the acute phase, the complication, and you want them to live in order for them to survive an open surgery later on. So it's still, even in those patients, using TVAR as a bridging tool emergently for a complicated case is still proven to have better outcomes. And so those would be my things to go. And I usually, if you have an IVUS, I would run the IVUS at the end of the procedure back up to the ascending to make sure that we don't have a retrograde type A. And if you do, you identify it immediately on the table and do that. And I'll just give a small example of how IVUS can be very good. I had a patient who came with some numbness in the leg, acute type B, but at first we kind of decided uncomplicated, but he worsened his pain and he worsened his numbness and ischemia of the leg. And so I, at that time, nothing was extraordinary of his pain, so I just assumed his type B is now complicated and took him to the OR. But I start my procedure routinely with putting a sheath up and going up with the wire and an IVUS to ensure that I'm in the true lumen. And as I got to the subclavian, I saw that the actually dissection is still extending into the arch, which was not the case in his CT from a day before. And so diagnosed that he had developed a retrograde type A medically, which the data shows that about 5% of patients can do that. Diagnosed that he had a type A, immediately moved him to the cardiac room, and he got his type A first repaired and the TVAR later. And so sometimes it's helpful for those diagnoses.
Luai, tips from your end, and also about that spinal drain. Do you put it routinely whenever you're putting those TVARs for acute dissection? You don't? Give us your tips, please, and then we'll ask Hazim.
Yeah. So I think everybody is correct in saying, size 1 to 1 or 10%, do not balloon. I haven't. I'm with Firas. I haven't found a good indication for petticoat. I think it's a good gimmick to increase the modeling of the dissection, but I have not had use. If I stent all the way down to the celiac, 99% of the time, you get the reperfusion of the visceral vessels. I think one of my partners used it once in the last 10 years. The
So you
spinal
routinely also go to the celiac, just to clarify, as close to the celiac as possible. So you end up with like.
So I'm between Firas and Rana. I tend to, if you go to the celiac, you are going to increase your risk of paraplegia. So depending on what I want to do, if I want to just get the patient off the table and I'm happy covering the entry tear is going to give me what I want, that's all I do. I get one piece, cover the entry tear, and get out, especially in the acute dissections. If I want more remodeling, I'm worried about rupture, like Rana mentioned. You want to go down all the way down to celiac. So I'm selective going down to the celiac. I don't do it on everybody. I decided based on what I want from the dissection. And then we're very fortunate. We have 24-hour coverage by anesthesia for spinal drains. I think you should not be doing these cases if you don't have some kind of agreement with either anesthesia, neurosurgery, neurology to put in emergent spinal drains in the middle of the night. And we've changed our practice to selectively putting spinal drains in only if they have paraplegia after the operation. And I think that's worked out well for us.
So Hazim, your turn, but just with respect to the spinal drain and sheath, etc. When you're about to do those cases and you're about to put the sheath, do you anticoagulate? Do you put the patient on heparin, or you don't put any heparin? What's your tips on that?
Thank you. Actually, these are very valuable practical points which were remarked. From my perspective, only to quickly to say, the key message is that the technical strategy in type B dissection should be individualized. We should not forget that. I fully agree that the true lumen access confirmation is critical and is very important by IVOS. But for me, there is a really very highlighted point should be always respected from my side, especially careful preoperative planning and planning the proximal and distal landing zone and the device selection. And what I try always to do, it's to minimize of arch manipulation. And always also lots of normal saline flushing, and if possible with CO2. I always try to flush always, or to use flushing with CO2 to reduce the silent stroke. Nobody knows. And what I try always to do is to avoid unnecessary aortic coverage. So I try always to cover the proximal tear and to wait and see if there is any possibility to be less harm or less how can I say less aggressive to the aortic treatment. I agree with Rana, selective revascularization of left subclavian, especially if there are planning of 20 centimeter length of aortic coverage, or if there is any kind of pre-existing abdominal aortic repair with the coverage of the EMA or internal iliac artery. For post-operative care, of course, I used to, and this point in which the TVAR is employed. So I try always to go with the middle blood pressure above 19. And always try according to spinal cord. I prefer to perform that post-operatively, even if I am going to the celiac trunk, if there is any kind of paralysis. That's why I prefer to fast-track protocol extubation the patients on the table and testing if any kind of cerebrospinal problem or not. So preventive, I am now taking a step hip back with the cerebrospinal preoperative cerebrospinal drainage.
Just so I understand it better. So you're not putting a spinal drain before the procedure. You're putting it only if when the patient wakes up, has a neurological deficit in their lower extremity. Is that correct?
Yes.
So are you Rana, Luay, Firas, is that, what's your practice? You put spinal drain before you start?
So I'm maybe a little bit biased because I work in an institution that our anesthesiologists are very experienced in putting it, so the rate of complication is lower. I trained, also did the open. So for me, it's an instinct, and it's usually, if it's doable, I'll do it. Having said that, there are sometimes complications, the inability to place it, if it becomes bloody, so you're going to hold off. My only caveat to people who are doing it selectively, which I think again can prove to be okay, is that you have the ability to have a rescue lumbar drain placement, right? And as I had mentioned, he has an institution, in his institution, they have an agreement of a 24 hours, but also you need to have an agreement that when there is an emergent need in the ICU, then within how long, it's usually within that same hour, they need to come and put that lumbar drain. It can't take them 5 hours to put a lumbar drain after the paralysis develops. So if you are in an institution that you don't think you can have a program that helps you do salvage lumbar drain placement, then I would suggest you get your team practiced and do it preventively when the team is there, when it's during the day, and you don't have to rush it. If you have the capabilities and you're able to do a salvage lumbar drain, then selective is definitely a reasonable approach.
How about anticoagulation? You give heparin after you put the large sheets in?
Yeah, so usually the biggest thing is they do the lumbar drain before, and then you can do the heparin. And if once you're done, usually you reverse the heparin. So if they need it emergently, we rarely encountered an issue with that.
Okay. I'm looking at the question. I think we went over the time, but I think this discussion has been amazing, and I personally learned a lot. And I always learn when people like Rana, Firas, Luay, Hazim are there, and learn from the questions that were asked or here on the one question that was. So in summary, Firas, you say like currently in your practice, you remain on medical first as your first line of therapy. You're still more to, but no, in your practice, everything gets randomized to the trial. So we can't say
100%. Yeah, 100%.
Yes, everything is
If
randomized.
if I show up in the emergency department, if any of you just randomize me, so that is. I tell you, one important consideration for the remaining audience is actually we didn't touch upon is the proximal landing zone, because
Yes.
this is really a key, because many occasions, and this has been shown, let's say in the stable trial, the complicated section, only 20% were within IFU. So you'll end up compromising on the proximal landing zone by ending in the left subclavian or zone 2, where you really should be in zone 1, or even zone 1 sometimes is not adequate, or you have a hematoma. So these are important consideration of timing, because if the hematoma is going to resolve in a week, that gives you a window for, if you have the luxury, if it's an uncomplicated or if it's randomized to TVAR, then you wait for the IMH to resolve. My point is, we compromise on the proximal landing zone, and that's where cardiac surgery eval may be necessary at times, because you may have to have a total arch. Actually, in the Sunday trial, and that's done in Scandinavia, that's I shouldn't say done routinely, but it's actually practice that you could get a total arch and then a TVAR because of these considerations. So proximal landing zone is a issue that is important to consider.
Could you expand on that a little bit? What do you mean? You have to compromise on the landing zone.
Well, I mean, if you have
A short neck, you accept a shorter neck, or you accept a
right. So
diameter. What exactly do you mean by compromise?
No, it's the length. So many times you have a tear that is within let's say 8 millimeter of the left carotid. Okay, so you do a carotid subclavian bypass, or you do a TBE and end up in zone 2, which is left carotid. but you have 8 millimeter that is potentially not adequate. So for that person, you're probably going to end up in zone 1. That's what I mean. It's not common. So you got to end up taking this into the other. You would do an off-label TBE and put the branch in the left carotid and do a carotid subclavian bypass, or just cover the left subclavian and go to zone 1 to the innominate. So the length of that is important. Definitely having a hematoma to the left up to the left carotid, then that limits really that increases your chance of getting a left retrograde dissection with whatever stent you're going to use. So you got to be careful. So these are two different things, mostly about the adequacy of the landing zone. And it's a well-known fact, less discussed. I had one time former SVS president says, "What's in a TVAR? You just measure up from the groin to here. You don't even need a fluoro. You just stick the damn thing there, and you just come out of the left subclavian and put a TVAR in." I'm like, I didn't know if he was joking or if he was serious, but I mean, I'm sure I take it that he was joking. But it's still, or just trolling me, which definitely could happen. Then
I'll add to what you were saying only one thing. And the only reason I'm adding this too is I'm taking into consideration where and what centers are we doing it. And I have to say that, again, in certain areas, we don't have the same capabilities and teams that we have where we have, right? So landing a TVAR in an IMH is usually recommended to land in a healthy aorta, but we all wish for that ideal patient, right? But if it means that you have to do bypasses and then go into do you have that ability? Do you have the ability to do that monitoring? Are you not? So sometimes if you're not able to do that and you're not oversizing, I've done where you're, I've in certain situations you've landed there. The problem if it's in a not healthy aorta or in a fully dissected arch, especially more than just an IMH, if the tear continues, is that there is a risk that the flow through that lumen might end up collapse your TVAR. And unfortunately, we've had 1 or 2 of those cases happen. So identifying and knowing that your proximal landing zone is healthy is good. And if you're in question, always I would consult the cardiac surgeons in the institution to try to make sure what is the best solution. Is it bypassing extra-anatomic bypass and moving it forward? Is it actually really trying to do something central and give you a landing zone? I think that's important for the discussion, because there are sometimes complications that if they do happen, then you're in a bigger trouble, and the only salvage is open, and then that's bigger and problem.
Well, once again, Firas, thank you very much for a great presentation. Rana, Luay, Hazin, thank you very much for great discussion and great teaching points. And this was a wonderful webinar for all of us. It is going to be taped. It has been taped, so other members who could not attend today should be able to go on PAVSS website. I would like to remind you that now we are all counting on you to become PAVSS members. So anyone in the audience who has not yet joined PAVSS, please join. It is our society, your society. It's a good opportunity for us to get to know each other better and to improve our practice, and for you to contribute to the improvement of care in our region. Thank you very much, everyone. Dr. Ma'moon is with us, the president of PAVSS, but I don't think he can comment. But I voiced his remarks and his thanks to all of you. Yalla, نهاركم سعيد.
Yalla. Thank you so much. Yalla, bye-bye.
Thank you.
Thank you. Bye-bye.
Thank you to Well Assemble. Bye-bye.